Welcome to the Executive Pulse with AIHE, where health leaders come to stay ahead of the curve on the issues that matter most. I'm your host, Dr. Sydney Chandrasiri, Chief Executive of AIHE, and in this episode, we're unpacking one of the most stubborn bottlenecks in our health system, the aged care bed block crisis. We already know it's not just a hospital operations issue, and it's not just an aged care workforce issue. This is a challenge that cuts right across governance, funding, policy, and leadership. And unless we deal with it strategically, it will continue to compromise hospital performance, patient safety, and the very sustainability of our health system. So over the next 10 minutes, we'll explore what the aged care bed block actually looks like on the ground, why it's become such a persistent and costly issue, and most importantly, what health leaders, executives, and boards can do differently to drive real change. Let's start with a very common scenario we see in hospitals. Imagine you're a nurse unit manager in a metropolitan hospital. Every bed on your ward is full. Half your staff are working double shifts. You're then told to prepare for an influx from emergency, but the problem is you can't discharge anyone, because 8 of your patients are older people who are medically fit to leave but are waiting for aged care placements that just aren't there. So those patients wait. The emergency department patients wait. The planned surgeries have to be delayed, and your staff morale sinks a little further. Now that is the reality of aged care bed block. Across Australia right now, thousands of hospital beds are tied up every day by older patients who no longer need acute care. They've been medically cleared for discharge, but they can't leave because the next step in their care journey, whether that's residential aged care, transitional care, or even appropriate home supports, simply aren't available. The result of this is that hospitals lose tens of thousands of bed days each year. Emergency department pressures climb, elective surgery lists grow, and the patients themselves, who are often frail, often vulnerable people, are exposed to the risks of long hospital stays, like loss of mobility, delirium, and hospital-acquired complications. But it's very important here that we understand and really appreciate that this isn't just about bed numbers. It's actually more about system design and strong leadership. So why has this become such a persistent issue though? Well, if we break it right down, there seems to be 3 forces at play here. Number 1, the aged care sector itself. Residential aged care facilities are under enormous strain. Workforce shortages, new compliance requirements, and funding pressures all make it harder for facilities to accept patients quickly, and some aged care homes simply don't have the staff or the capacity at all. Number 2 is the assessment and discharge process. Navigating the ACAT assessments, the approvals, the funding streams, and placement logistics are unnecessarily complicated and onerous. And too often, discharge planning starts too late and then gets bogged down in red tape. And number 3 is fragmented accountability. Hospitals are funded to deliver acute care, but aged care is funded separately and differently, which means that any misalignment or mismatch increases the risk of patients falling through the cracks between these two structures. And the cost ends up spread across the entire system, but quite often in the most expensive parts of the system. So aged care bed block is not just a byproduct of hospital overcrowding, it's actually a signal of deeper misalignment between sectors. Now, this isn't a problem that frontline clinicians and staff can fix alone, and this is where healthcare leadership comes in, because it requires executive-level governance, smarter strategy, and clever partnerships. At AIHE, we see this challenge as a real leadership opportunity, because solving aged care bed block requires health executives and boards to shift from reactive management to proactive system stewardship. But at this point, you may be asking, well, what healthcare leaders can even do differently? Well, firstly, we can strengthen the hospital aged care partnership. We see too often that hospitals and aged care seem to operate in almost parallel universes. But when strategic partnerships are formalized, Whether that be through joint workforce models, shared care pathways, or transitional care units, we create smoother flow for patients and more efficient use of resources. Interestingly, some health services are piloting transitional care wards that are co-staffed by both hospital clinicians as well as aged care nurses. That type of setting, you can see, can provide safe environments for older people who are waiting on placements, which would free up the acute bed capacity but still maintain the right standard of care for those patients. Now, I'm sure you've often heard about streamlining discharge and expediting placement pathways. But right now, discharge planning can feel and is quite chaotic. But there are some ways in which we can drive some real change in this space as well. Investing in better case management, for example, or using digital platforms that connect hospitals with aged care providers in real time, and establishing clearer accountabilities for each step in the transition processes themselves can make some meaningful gains. Enabling these can then result in discharge planning that's treated as a strategic priority and not just as an administrative task. That's when we tend to see faster flow and smoother transitions. And finally, there really is no way of getting around the need to invest in some new models of care. This could mean expanding hospital-in-the-home programs for older patients, creating more community-based transitional care options, or developing some innovative out-of-the-box partnerships with providers who can offer the type of subacute step-down service that your acute unit needs. Every such innovative model has the power to reduce our current reliance on high-cost acute beds. But honestly, we all know that these changes are obviously not easy. They require our healthcare boards to actually think differently about cross-sector partnerships. They require our executive teams to actively break down silos and negotiate across funding boundaries. But most importantly, they require sheer will and courage to reallocate resources, to test new models, and sometimes even to challenge existing policy constraints. And that is why this is a leadership issue at its core. Let me share one example from a health leader we recently spoke with. Now, their hospital was facing chronic bed block. But instead of pushing harder on their discharge systems alone, they did something different. They approached 3 aged care providers in their region and proposed a joint solution, a transitional care unit that would be co-funded by both sides. Well, it obviously took a lot of negotiating and months of planning, but once it was in place, they saw a huge reduction in delayed discharges. And the aged care providers had more predictable admissions. And most importantly, the patients were able to transition much more smoothly into the right setting for the type of care that they needed. And that's the kind of system leadership that we're talking about. So if you're listening today as a health executive or board director, here are some questions that may be worth reflecting on. Do you know how many bed days in your hospital are lost to aged care delays? What partnerships with aged care providers does your organization currently have in place? And how strong are they? Where in your governance structures is discharge flow treated as a board level risk and as a strategic priority? And what innovative models have you considered testing to break some of your bottlenecks? These aren't abstract questions. They're leadership levers that you can start to use to begin a conversation at your organization. Aged care bed block will not be solved by adding more hospital beds alone. It will be solved when healthcare leaders decide to truly commit to rewiring the system between hospitals and aged care, by aligning incentives and by actually designing care pathways around patients. Well, that's it for today's episode. The aged care bed block crisis is definitely complicated, but it's also an opportunity for courageous leadership and smarter strategy. You can read the full AIHE publication on this topic at aihexec.com/publications. And if you found this episode valuable, please share it with your board, your leadership team, or your colleagues who also need to be part of this conversation. Thank you for listening. This has been the Executive Pulse with AIHE. Until next time, lead with insight, with integrity, and lead with impact.